There you go. Yep.
Yeah.
Okay. You're recording.
All right, cool. What's
Yeah,
that?
we're live.
So we started about Calcar fractures. That's what happened last week, and okay, this is my last case or whatever. One of the cases last week.
Yep.
So the first question we have is, what is a calcar? There's the femoral head and neck. Can you guys see the mouse on the screen?
Yep.
All right, cool. So this bone right in here is the calcar. You see how it's nice and thick, beefy? If you imagine the weight of the person coming down here, pushing on the femoral head as they're holding their weight up, you would imagine this area is under a lot of stress, right? That's why it's so thick. Something called Wolff's Law, where bone models and gets thicker and harder and more resistant against areas of stress. That's why when astronauts go up into the space station, they have to constantly exercise because there's no gravity and no stress, and so the bone's like, I don't need to be any stronger, I'm going to demineralize. So that's the calcar. This is where we cut the femoral neck. I just realized the text isn't that easy to see in the green. Sorry, there's a lot of green text in here.
No, that's fine.
All right.
We can see it.
And then, this is a picture of a brooch inside the bone. You can see the femoral neck cut. You can see how the brooch is wedging inside of the bone. If we look at, this is looking at the bone from the very top, like the cut surface, you're looking down as if you're going to go down into the bone. And this is the brooch or the stem in the bone. And it's loading the bone with things called hoop stresses. So it's sort of wedging in there, and it's kind of applying a force on the bone in the front, in the back, on the sides. A calcar fracture is when you're either broaching or you're putting the stem down, and those hoop stresses are too much, and the hoop of the bone breaks, and you get a little line right there on the cut surface of the bone. It's not very easy to see. It's kind of, I should have blown this up a little more. I drew this little line down here. That's kind of how it looks when you see it on the surface of the bone, and you go, well, is that real? Or is that just a saw mark? Because sometimes, like when you're doing the saw cut, it kind of goes this way and then that way, and you have a little bit of a step off, and it looks like a fracture. So if you're in the OR with me, every once in a while you'll see, like, we'll have the brooch, and we'll be about to check at the trial neck, and real quick, I'll like look over and like suck it really fast. And, okay, it was just a piece of like a little bit of blood that looked like a calcar fracture. The problem with this is if you just leave it and you don't treat it, it will propagate and continue further down the bone. When it happens in the OR, you're looking at the bone as you're impacting the brooch and the stem in and out. So usually the second that fracture occurs, you see it and you go, whoop, and then you curse. And then you look at Jason and go, get the cables. So fracture can propagate further down the bone if you don't treat it. So if you treat it, and there's a cerclage cable around the bone, you can imagine, if you have this little crack right here in the bone, if you wrap a metal cable around that bone and tension it, that crack's not going to spread. It's not going to go anywhere. So if treated, usually they don't have any more pain. They always ask me when this happens. It happens probably like 2 or 3 times a year. They're like, oh, it's a break. Is it going to hurt more? I tell them, like, it really doesn't seem to. In fact, usually I do their other side. I don't break their hip on the other side, and they usually come back and they say, this side hurt more than the one you broke. And they go, well, I told you it doesn't make it hurt anymore. It's always different the second time around. Fully weight bearing, I will tell them, maybe don't jump on a trampoline tomorrow. And they go, oh, I wasn't planning on doing that anyway, ha ha ha. But it gets the point across that, like, yeah, there's a break, but we treated it, you can put all your weight on it, just like, don't be crazy. Like, just understand that, there's a little bit more that happened, take it a little bit easier. They always ask if the cable needs to come out. No, it doesn't. They can stay in place. Jordan Greenbaum, who maybe one or two of you may have met, he was at our practice before I joined. He got to a point where he was putting cerclage cables on every hip, just prophylactically, because he was worried he was going to cause a calcar fracture. So when I have a patient that comes into clinic for the left hip and the right hip has been replaced and it's got a secure fit and they got a cable around it, I go, oh, Dr. Greenbaum, do your other hip? They go, yeah, how'd you know? I've seen a lot of his x-rays, And yeah, you promise them that you'll try extra hard not to break your hip when you do the other side. And they usually remind you, grab it, hey, don't hit it too hard. No, I won't. If you don't notice it, if you don't treat it, you just go, oh, I don't know if that's real. Maybe it's just a line in the bone, and you just let them weight bear on it. That fracture is going to propagate, and you see how it kind of just continues down the bone. And once it goes down through here, this stem is no longer stable. The bone is like, it's wiggling in the bone. The bone's not going to grow into the stem, and the patient's going to need revision surgery where you have to take the stem out, cable the fracture together, now with multiple cables because the fracture goes down way further, and then use a revision stem that goes all the way down, like halfway down the bone. So what was this about? So you gotta get the cable around the bone, right? And you use these cable passers to get them around the bone, and there's different shapes and sizes. Those are the ones that I needed. And it kind of has to do with like the entry versus the exit point. You see how like the bottom two, it's sort of everything's in a line, and this like gooseneck comes way out like that. It's an anterior hip thing. Over here on the right, the blue arrow is sort of the approach we're taking for the anterior hip. So we're going down on the front side of the thigh. This is the tensor fascia lata muscle, and we open up the fascia of that muscle, we pull it out to the side, go through the floor of that fascia, and then right in between these other two muscles here is the hip joint capsule. We open up the capsule, we make our neck cut. So you have to get an instrument through the skin here and around the bone here and on the other side. It's really hard to do that, at least for me, with this thing. When I'm at the hospital, like I said, I get a Calcar fracture 2 or 3 times a year. And invariably they open up the things, I pull them all out. I'm like, nah, these don't work, get the other ones. Like there's another one that's shaped differently, and I don't remember exactly how it's, now I do, because I've like looked at these pictures a million times doing this presentation. So, next time this art will be better. Also, I texted that to Jason because he was over at the hospital, and I just want to make sure because I've done this to Jason like times where like, no, not that one, the other one. So I have to be like, oh yeah, the other one, I'll get it. So like, here's that one that I don't like that I say works, badly, and it's like, oh my God, look at that, that's perfect, right? It's fit exactly right. Look at it, goes right around, it goes right down, right through the interval, right? Yeah, but good luck getting it around the bone, right? You gotta get this tip around the bone, and with this big giant gooseneck on it, in order to do that, you basically have to have like the handle like through the stomach. So anyone who's in the room with me is probably hearing me probably like, this is for distal femur replacements. Yeah, I have to put my handle through the stomach in order to do this. The other handle, yeah, you see how like you can get that tip around the bone without having to go quite so far around. So that was basically it. I needed this thing, and I was a little bit worried that they were going to give it to me, and I was still going to take like 30 minutes to get it around the bone. And you guys are going to be like, he just doesn't know what he's talking about. He just did it all the way. But yeah, they put it in my hand, and it was only like a second later. I was like, all right, we're done. So that's what happened. That's sort of the situation. It's a little unique feature with the anterior hips. There's lots of little unique things with the anterior hips that like you learn through trial and error over the course of years of doing it. That's why the learning curve for this type of surgery is so large, because like something happens and you realize, oh wow, all the instruments that like are for posterior hips don't really work. I need to figure out some other way to get around this thing. I think that's the last slide. Yes, it is. What questions do we have?
We have those here, or we borrow them.
We have a loaner tray right now until we get our own.
Yeah.
Okay. Okay.
Do you ever have a fracture that can't be approximated by the cables?
No. It's possible. You gotta be not paying attention though. Like I said, when we're broaching, my eyes are just burning that bone every time I hit the mount. I'm not really looking at the broach of the bone, I'm looking at the bone there. So that when that crack occurs, like you see it goes like that. Yeah, if you're not paying attention and you just kind of keep hitting it, yeah, you could propagate that crack down the bone. And with an anterior hip, that would be really problematic. In order to get exposure down the bone, technically the anterior approach is not very extensile. Like with a posterior approach, you can just kind of extend the skin and just, go further down and expose all of the bone. That's why when we do a periprosthetic fracture, like I did one last week in the hospital, spiral fracture all the way down the bone, posterior approach all day long. Just go back there, you can expose the whole bone, put the fracture back together, put the cables around. With the anterior approach, if that happens, I've literally never been in this experience before, so it'll probably be very, very stressful if that happens, but you have to detach the tensor fascia lata off of its origin and then do this curvilinear incision further down the bone and get on the other side of the muscle to expose through a separate interval. I saw it once in fellowship. It was not fun. The attending was cursing all day. So again, that's why we're extra careful when we're broaching, and like every time I hit that nail, I'm looking at the bone, the second you see a little line, you go, whoop, and then hit the cables.
Do the cables come in different sizes, or do you generally use the same size?
No, they're all one size, like one size fits all. The cables we use here are like, they're actually the same as what we're seeing here. It's called a Dahl Miles cable. There's other types of cables. They have different mechanisms for like tensioning and crimping and stuff like that, but they all function about the same way.
Okay.
Do you have any restrictions if that should happen? Do people have any, minus the don't jump on a trampoline? Do you have any other restrictions at all?
No.
Sure.
Sometimes if their bone is really, really terrible, they're like, 85-year-old lady and their bone was just like dust. Like every once in a while you'll see me do like the first 4 or 5 broaches with my hand. I just put the broach in and kind of do that and like put the next one in and do that. And it's not until the last one I'm actually using the mallet. The patient with bone like that, I will generally tell them, like, I don't want you really putting all your weight on it. I want you to take it very easy. Maybe use a walker for a couple weeks until you see me back. But someone with relatively good bone quality, when you get that cable tensioned around it, like, you could hit that thing hard and it's not gonna go anywhere.
Turnover and moving help room 1, please. Turnover and moving help room 1.
Any other questions?
That's very cool.
All right, thank you.
Thank you.